For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.
Welcome to the deep dive. Today we're tackling a subject that, well, it can cause a lot of stress for healthcare workers. Needle stick injuries.
It really can. It's something that happens, unfortunately.
Exactly. But the good news is there are very clear, established guidelines and NHS guidelines designed to manage these situations and hopefully reduce that worry. So our mission today, to break down that protocol, give you a real shortcut to understanding what happens step by step.
And it's important to see this isn't just, sticking a plaster on it. It's a whole process.
Right.
A time-sensitive one involving medical checks,
Yeah.
maybe preventative treatment. Understanding it is key, really, for anyone interested in how we handle these critical health risks.
Okay, so let's dive right in. An incident happens, needle stick. What is the absolute first thing, the very first thing you do? Seconds count here, right?
Absolutely. Seconds. The immediate priority is first aid at the scene. First, encourage the wound to bleed.
Encourage bleeding. How do you do that?
Just gently squeeze the area around the puncture. Doing it under running water is ideal. Helps flush it out as it bleeds.
Okay, squeeze gently underwater. Got it. What's next?
Then, wash it really thoroughly. Plenty of running water and soap. And keep washing for several minutes.
Several minutes, okay.
Yes, give it a good clean. Now, here's something crucial what not to do.
The don'ts. Always important.
Definitely, do not scrub the wound.
Really? I might have thought scrubbing would clean it better.
It sounds like it would, but scrubbing can actually damage the tissue more. And that damage, paradoxically, might make it easier for a virus to enter.
Wow, okay. No scrubbing. What else?
And don't suck the wound. Definitely not.
Right, no sucking. Makes sense. So after washing.
Pat it dry gently, and then cover it with a waterproof plaster or dressing.
Okay. What about splashes? Say blood gets in your eye or mouth. Is the advice different?
Yes, it's a slightly different approach. If blood splashes in your eyes, you need to irrigate them immediately.
Irrigate, like flush them out.
Exactly. Use lots and lots of clean water, or saline if it's available. Just keep flushing.
And the mouth.
Rinse your mouth out thoroughly with water. Do it several times. Spit the water out each time. Absolutely do not swallow it.
Okay, so don't swallow. That's key.
Very key. The goal is always dilute and remove quickly.
Right, let's quickly recap those first few seconds then. Encourage bleeding, wash really well with soap and water, but no scrubbing, no sucking. Then cover, splashes, flush eyes massively, rinse mouth repeatedly, don't swallow. Speed is vital.
That's it. You've got the immediate actions down. They lay the groundwork.
So first aid done. What's the next step? We're talking minutes, maybe hours later now. This is where the clock really starts ticking for treatment, isn't it?
You've hit the nail on the head. Immediate reporting is absolutely critical. The most critical step, arguably, for getting timely help.
Okay, who do you report to?
Report straight away to your manager or the nurse in charge of your ward or area. Don't put it off.
No waiting till the end of the shift or anything.
Absolutely not. Then you need to contact your local occupational health service urgently, as soon as possible. They're the experts here.
Okay, occupational health. But, what if it happens at 3 a.m. or on a Sunday? OH departments aren't usually open 24/7.
That's a really important point, and the system accounts for it. If occupational health is closed, you go directly to the nearest A&E department, accident and emergency.
Okay, so there's always somewhere to go immediately.
Always. Every NHS trust has a 24/7 protocol specifically for this. The message cannot be clearer. Do not wait. Waiting could mean missing the window for effective preventative treatment.
Right, that makes sense. What about information? Should you try and find out anything about, the source of the needle?
Yes, if it's possible and safe to do so. Try to get the details of the source patient, their name, their hospital number.
Why is that so important?
Because that information allows healthcare staff to ask the source patient for consent to do rapid blood tests. Testing for things like HIV, hepatitis B and C. Knowing their status helps massively with the next stage, the risk assessment.
So again, that no delay message is key. Immediate first aid, immediate report, immediate contact with OH or A&E. Don't wait.
Precisely. Delaying any of those steps can have serious consequences for the effectiveness of what comes next. Which brings us neatly to that next phase. Once it's reported, how do the professionals figure out the actual risk? And what happens treatment-wise?
Yeah, that's the big question, isn't it? Because presumably not every single needle stick is, super high risk. How do they tell?
You're right, the risk varies a lot. A healthcare professional carries out a detailed risk assessment. It looks at two main things. First, the exposure itself.
The injury.
Yes. Was it a deep puncture? Was there visible blood on the needle or syringe? Was the needle used in an artery or vein of the source patient? These things suggest a higher risk.
Okay. And lower risk would be?
Things like a superficial scratch, maybe an injury from a solid needle like a suture needle used for stitching or exposure onto intact skin. Those are generally lower risk.
Right. That makes sense. Deeper injury, more blood, potentially higher risk. What's the second factor they assess?
The second factor is the source patient. And this is where their HIV status becomes really central.
Ah, okay. So what if you don't know their status?
If it's unknown, the source patient will be asked for their consent to have a rapid HIV test. Getting that result quickly is obviously very helpful.
And if they are known to be HIV positive?
Then the single most important piece of information is their current viral load.
Viral load. And this is where that UU thing comes in. Undetectable equals untransmittable.
Exactly. This is such a crucial piece of science. If the source patient is HIV positive, but their viral load is undetectable, meaning the treatment they're on is working so well there's virtually no virus circulating in their blood, then the virus cannot be transmitted sexually. And for needle sticks, the risk is considered negligible.
So if you might not even need preventative treatment.
Often, yes. If the source is undetectable, post-exposure prophylaxis, or PEP, is frequently not required. It's a huge relief and changes the conversation completely.
That's amazing progress. But what if the viral load is detectable, or the source patient status is unknown, or they decline testing?
Then PEP will be recommended, almost certainly.
Okay, so let's talk about PP. What exactly is it?
PEP stands for post-exposure prophylaxis. It's a course of medications, specifically antiretroviral drugs, the same kind used to treat HIV.
And the aim is?
The aim is to stop the virus from establishing itself in your body after an exposure. It's taken for 28 days.
And timing is critical, right? We keep coming back to that.
Absolutely critical. PP needs to be started as soon as possible, ideally within hours.
Hours, not days.
Definitely hours. The sooner the better. Its effectiveness drops off significantly over time. It's generally not recommended if more than 72 hours have passed since the exposure. It's just unlikely to work by then.
Wow, 3 days is the absolute cutoff. That really underlines the urgency.
It really does. Every hour counts in that initial period.
So what does this PP medication involve? Is it just one pill?
No. The standard first-line regimen recommended in the UK usually involves a combination of 3 different antiretroviral drugs taken together.
3 drugs for 28 days. That sounds quite intense. Are there side effects?
Yes, there can be. Like many potent medications, these can cause side effects. Things like nausea, maybe diarrhea, headaches. Feeling tired are quite common.
Are they manageable?
Usually, yes.
Yeah.
They tend to be worse at the start and often settle down. But it's really, really important to complete the entire 28-day course, even if you get side effects. Adherence is key for it to work.
Right. Stick with it for the full month. So putting it all together for someone in this situation, understanding that UET is huge for potentially avoiding PP, but if it is needed, that time window starting within hours, absolutely within 72 hours, is non-negotiable.
That's the critical takeaway. Quick assessment, informed decision, and very prompt action if PP is indicated. And thinking about the bigger picture, starting PP if needed is a major step, but it's not quite the end of the story. There's still follow-up involved.
Ah, okay. So even if you take the preventative medicine, they still need to monitor you.
Yes, absolutely. Follow-up testing is mandatory. It's to make absolutely sure that seroconversion hasn't occurred.
Seroconversion meaning that the person hasn't developed HIV despite the PEP?
Exactly. So the first test is actually done right at the beginning when PP is started. That's a baseline test.
To make sure you didn't already have HIV before the incident.
Precisely. Then there are follow-up tests. Typically, these happen at 6 weeks after the exposure, and then again at 12 weeks.
12 weeks? That's 3 months later. Why so long? Are the tests not very quick these days?
Well, modern tests, the 4th-generation tests, are very sensitive. You're right. They can often detect an infection much earlier, sometimes within 4 to 6 weeks.
So why wait until 12 weeks for the final all clear?
The 12-week test is still considered the gold standard in the UK for giving that definitive negative result after an exposure. It just provides that absolute certainty. Peace of mind.
I can imagine needing that peace of mind. The whole process sounds incredibly stressful. From the injury itself, the uncertainty, taking the meds, waiting for test results.
It really is. You've hit on a vital point. The psychological impact, the anxiety, It can be huge.
Is there support for that side of things?
Yes, and it's crucial. Counseling and support are built into the process. Occupational health services are key here, but your GP can also provide support. Talking about the stress, getting reassurance, it's really important throughout that follow-up period.
That's good to hear. It's not just about the physical side, but the mental well-being, too. It feels like a very thorough, supportive process, even though it starts with something quite alarming.
It aims to be, yes, holistic care.
Okay, let's try and boil this all down. To bring everything we've discussed together, what are the absolute core principles, the key takeaways from the NHS approach?
Right, we can summarize it into about 5 key points, I think. These are the pillars of the protocol.
Go for it.
First, immediate action. That first aid. Wash the wound, encourage bleeding, straight away.
Got it. Number 1, act fast at the scene.
Second, no delay in reporting. Tell your manager, contact OH or go to A&E immediately because
Okay.
PEP is so time critical.
Right. Number 2, report instantly. Time matters.
Third, risk assessment. A professional will assess the risk properly, looking at the injury and the source patient. This decides if PEP is needed.
Okay. Number 3, proper assessment is essential.
Fourth, PEP is effective. If it's needed and started quickly, PEP works very well at preventing HIV. It's a powerful tool.
Good. Number 4, trust PEP if it's recommended early.
And finally, fifth, follow-up is mandatory.
Mhm.
You must complete the full PEP course if prescribed, and you must attend all the follow-up blood tests, no skipping.
Excellent. Number 5, see it through to the end. Wash, report, assess, treat, follow up. That covers it.
Yeah.
You know, when you lay it out like that, it's actually quite incredible, the amount of detail, the 24/7 readiness, all for something that starts as an accident. It really shows how seriously healthcare workers' safety is taken.
It does. It's a robust system built on experience and science.
And even if you listening aren't a healthcare worker, understanding this kind of protocol gives you a real insight into the safety nets that are in place.
Absolutely. And maybe a provocative thought to leave with. What does the very existence of such a detailed round-the-clock protocol tell us?
What do you think?
Well, I think it speaks volumes about how much we value the safety of healthcare staff.
Yeah.
But also it shows the progress, doesn't it? The scientific advancements like UN, effective PP, combined with that human diligence in creating and following these procedures. It's public health in action.
That's a great way to put it. Diligence and science working together. Being informed really does give you confidence, doesn't it? Knowing these steps exist.
Knowledge is power, as they
No,
say.
it truly is.
Hey,
Hopefully this deep dive has given you that clarity. If you or someone you know faces this situation, remember these steps and know where to turn.
your local NHS Trust Occupational Health Department, find out their emergency contact before you need it.
Good tip.
Yeah.
And if OH is closed, your nearest A&E.
Always. And for UK healthcare workers, there's also the National Needle Stick Hotline, 0844-811-055. That's a 247 dedicated line.
Excellent resource. Okay, that's all for this deep dive. Until next time, stay curious, stay informed.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.